So, hello, good evening, respected seniors and my dear friends. We welcome you all for the eighth session of ISCCM Journal Club. I am Dr. Tanmay Ghatak from SGPJMS Lucknow. Along with me is Dr. Raghav Gupta from AIMS Delhi as a club coordinator for this ISCCM Journal Club. And as you all know, the ISCCM Journal Club is conceptualized by our respected President-elect, Dr. Ranbir Tagi sir. We wholeheartedly thank you, sir, for giving us this opportunity to serve for ISCCM and continuously blessing us. The tagline of ISCCM Journal Club is simplifying evidence-based medicine to bedside medicine. That means so that we can practice and prescribe evidence-based medicine into bedside practices. The theme or the motto or the target of our ISCCM Journal Club is to dissect or know the recent practice-changing research articles, try to imbibe them, those breakthroughs into our practices, and ultimately homogenize the critical practices in our country. So with this overview, I want to welcome our respected guides. Firstly, Dr. Manish Bharti sir, who is Associate Director and Head Critical Care Indian Spinal Injury Center, Delhi, and Dr. Neeraj Kumar, who is Associate Professor from AIMS Patna. Both of them actually started this and guiding us for the last 4 5 ISS Journal Club. Welcome, welcome both the doyens. And our expert for this journey is the leader of research methodology in our country, you can say, Professor Rakesh Garg sir from AIMS. It gives me immense pleasure to sir to have you here. I welcome
Thank
you,
you, sir.
dear sir, Rakesh sir.
Thank you, sir.
So. Uh, Thank you. We have today two wonderful studies for presentation or dissection or critical appraisal, you can say. So both of them are multi-centered trial and published in this year. And first study is from NEJM, having 700 plus patients from 23 centers. And while the second study is from 43 centers, having 640 patients and published in JAMA Network Open. So without much delay, let's start our first study, that is proportional assist ventilation for minimizing the duration of mechanical ventilation, and it is to be presented by Dr. Deepangshu Rai, who is a senior resident from Department of Anesthesia and Intensive Care, PGIMER Chandigarh, and is to be mentored by my dear brother, dear friend Somo Sarkar, who is assistant professor, Department of Anesthesia and Intensive Care, PGIMR Chandigarh. Welcome both of you. Hello and welcome to the show. And over and again, I'm saying that it is a time-bound exercise. Please finish the presentation by 16 minutes, 15, 16 minutes, so that we can have a healthy and fruitful discussion by 7:30 or so. Hai na? So, and move to the next topic for discussion. So, over to you, Dr. Deepangshu.
Good evening, everyone. So, for today's journal club, we are going to present an article.
Kindly share your screen.
Yes, sir. So, good evening, everyone. So, for today's journal club, I'm going to present a promising trial that is proportional assist ventilation for minimizing the duration of mechanical ventilation. This trial got published in New England Journal of Medicine this year in the month of September, presented by myself, Dr. Dipanshu, and moderated by Dr. Soumya. We need to understand a little background about this trial. So the problem statement is that around 20 million patients annually require mechanical ventilation, and every third of this patient ends up facing some difficulty or getting weaning prolonged. So this prolonged ventilation has higher complications. Patients end up getting more higher mortalities, long-term disabilities, and cost is increased for the patients who end up getting prolonged ventilation. Hence, the duration of ventilation is a very key modifiable factors when it comes to determining the long-term outcomes. in the ICU, we have certain guidelines to shortcut or to decrease this duration of ventilation, such as daily sedation interruption as well as spontaneous breathing trials. But at the same time, we don't know what is an optimal ventilation mode which can help in reducing the weaning failure. So, we also need to understand that in the ICU, very commonly, or in the initial phase of the mechanical ventilation, we put the patients on controlled ventilation, which, if prolonged, can cause respiratory muscle deconditioning and lead to prolonged weaning. So, proportional assist ventilation, also called as PAV plus mode by definition, provides proportional pressures or proportional effort, provides pressure which is proportional to the patient's effort rather than a fixed pressure or a fixed volume, such as given in the SI or your assist control modes. The mechanism behind this proportional assist ventilation mode is it exploits the equation of motion and shares the elastic and the resistive loads by the paradigm, and hence it amplifies the patient generated pressure, which is proportional to the pressures which is generated by the patient itself. In this mode, the main determinant or the main factor which you input in is the gain setting, which is determined or presented in percentage. So the percent assist, it determines that how much work of the breathing will be done by the ventilator itself. It could be 10%, it could be 50%, it could be 110%. And this and these breaths are patient controlled flow. The volume and the timing are all controlled by the patient. Hence, it is more physiological, it is more natural, and it improves the synchrony, a problem which is faced in controlled modes. So, if we talk about the clinical use, it will be useful during weaning when the patient is facing dysynchrony or pressures which usually occur on the pressure support mode. If you compare this with the pressure support mode, in which there is over resistance, and if PSP mode is given for a prolonged time, it can cause diaphragmatic atrophy and can result in dysynchrony. On the other hand, PAV plus mode delivers assistance which is proportional to the patient effort, and hence it is more physiological. Also, the evidence suggests that the PAV plus mode improves synchrony, it reduces dyspnea, and also enhances the sleep quality. So, with this background in mind, a hypothesis was created which stated that PAV plus mode, when used early after the acute respiratory failure, will result in a shorter time to successful ventilator liberation as compared to the PSV mode. Successful ventilator liberation was defined as extubation, following which for the next 7 days the patient is not re-intubated again. So the objectives for this study were one primary objective and certain secondary objectives. The primary objective was time from randomization to successful liberation from the mechanical ventilation. And then there were certain secondary objectives as well, such as time from randomization to the live discharge, incidence of re-intubation, tracheostomy, death in the ICU, in the hospital by the day 90, total number of ventilator-free days, the level of weaning difficulty or any associated weaning complications, and the tolerance to the assigned mode. In the methodology, this study was an investigator-initiated, multi-center, open-label, randomized superiority trial. It took place in 23 hospitals over 7 different countries. The recruitment for this study started from September 2016 and it ended in June 2023 with a temporary pause during the COVID era. The inclusion criteria for the study were any critically ill patient who is greater than 18 years of age and he or she is on ventilator for at least 24 hours. And that specific patient is able to tolerate pressure support ventilation mode for 30 minutes. Any patient who is had severe chronic respiratory disease, neurological disorder, who is anticipated to be withdrawal from the life support, or if they have successfully cleared the spontaneous breathing trial and are a candidate for extubation in the coming 24 hours are excluded from this trial. For the randomization, it was done via a centralized web-based system and a computer-generated sequence was created. 1:1 allocation was done and that was even stratified according to the center. As far as blinding is concerned, it was open label for the clinicians and the research staff, but at the same time, the person who was the trial statistician was blinded to the group allocation. Some more detail about the study protocol. As I've said before, it was a centralized web-based randomization was done in a 1:1 ratio. The patients who were in the PAV plus mode, proportional assist ventilation mode, in those specific patient, gain was adjusted so that the peak respiratory muscle pressure got up to in the range of 5 to 10 centimeters of water. And for the patient who are in pressure support ventilation mode, their parameters were adjusted such that the respiratory rate was somewhere between 12 to 35 breaths per minute, and the tidal volume was somewhere between 5 to 10 ml per kg of predicted body weight. Both of these patients, both of the patient group underwent spontaneous breathing trial daily. And even the guidelines for sedation, their nutrition, and early mobilization were provided to the clinicians. Here we can see a simplified way in which they underwent the staged screening or the stage enrollment for the patients. The screening or the enrollment for the patients were done in a successive stepwise manner. And in all of these steps, there were certain inclusion and exclusion criteria. For example, initially the patients were screened with the simple question that whether or not they are greater than 18 years of age and if they are on a mechanical ventilator for more than 24 hours. That was simply the criteria for screening. Certain patients who got screened and then they got up to the enrollment criteria. Similarly, enrollment criteria again had its own inclusion and exclusion criteria. And you can see this is simply how they ended up getting 573 number of patients for their trial. So here we can see that screening at the level of screening, at the level of enrollment, again at the level of PSV trial criteria. Then they tested the patient if they are eligible for weaning or not. So if the patient is eligible for weaning, they will not keep this patient for the study. So this is how successfully they did the steps and tried to figure out as to how many number of patients will be taken in for the trial. Talking about the sample size collection, initially the study was done over 120 patients, from which re-estimation was done for the study. They took the median liberation time of 6.8 days and figured out that they will need greater than 558 patients for an 80% power and an alpha error of 0.05. They also assume that at the same time there will be less than 5% loss to follow-up. And the statistical analysis, they had both the kind of analysis, intention to treat as well as per protocol analysis. And the primary outcome, that is the number of days since the time of randomization to the liberation, was shown using cumulative incidence curves. And the cumulative incidence curve were compared using the Gray's test. Since the patient who are enrolled in this study were studied or were observed on various stages of their management. For example, first when they were intubated, then when they were extubated, then when they were in ICU, and then maybe they got tracheostomized or reintubated again. So multi-state Cox proportional hazard model was used for the statistical analysis. As far as sensitivity is concerned, the liberation was defined as 48 hours of the ventilator. And the adjusted model and the baseline covariates were also used. No interim analysis was performed for this particular study. So this is the consort diagram for this trial, and in which we can see that initially for the eligibility, more than 10,000 adults were screened. And after that, 6,610 were potentially eligible, out of which they did the screening, they did the test, and 722 were enrolled, from which only 575 were randomized. From these 575 patients, they got divided into two arms, one in the proportional assist ventilation group and then in the pressure support ventilation group. These are the results of the study. As we can see that the baseline variables, be it the age, gender, BMI, Apache score, they all are comparable. Again, these are some more baseline variables such as use of the neuromuscular agents, the dosage of the sedative agents which were used, or median cumulative fluid balance. All of these parameters are comparable in both the groups. So coming to the results of the study, the primary outcome, that was the number of days for successful liberation from the ventilation, we can see that in the PAV plus mode, it is 7.3 days, and in the pressure support ventilation mode, it is 6.8 days. And the hazard ratio for this particular outcome is 0.96. which suggests that there is absolutely no difference, or a PAV plus mode doesn't show any superiority over the pressure support ventilation group when it comes to successful liberation from the ventilation. And along the results were pretty much similar along the same lines when it comes to other secondary outcomes as well. For example, the median number of ventilator free days, number of deaths at different time points in the ICU, in the hospital, at the day 90, the time when the first spontaneous breathing trial was given, or when it comes to what was the level of difficulty, whether it was short, difficult, prolonged. All of these parameters showed that PAV plus had no superiority over PSV. Since since one lies in between the 95% confidence interval. So this is the cumulative incidence curve, in which we can see two different curves. First is successful liberation from ventilation, and second is the death before liberation. Because in this particular study, death is a competing risk, which is why the authors tried to depict both of these outcomes at the same time in this particular curve. So on the y-axis, we can see the cumulative incidence, and on the x-axis, we have days since randomization, starting from day 0 till day 90. Where we can see that the both proportional assist ventilation and pressure support ventilation have a similar trend when it comes to both the successful liberation as well as death before the liberation. Similar outlines or similar curves were observed when we tried to depict live ICU discharge or death before the ICU discharge. And the fashion or in which live hospital discharge and death before hospital discharge got depicted is along the similar lines. They also were a little dubious about whether certain parameters had some influence over our results. For example, parameters like the duration of mechanical ventilation, parameters like if what is the baseline frailty of the patient. So they also did a subgroup analysis. Here, for example, we can see duration of mechanical ventilation, where they did subgroup analysis of less than 5 days or greater than 5 days. Even upon doing the subgroup analysis, they find out that there is no significant difference, or there is no superiority of the PAV plus mode over the pressure support ventilation mode. So if we talk about the discussion, if we discuss about previous trials which were done along the similar lines, we can see that these are the different trials which were done in the past. For example, the study done in 2018, which showed that PAV plus had a clear evidence of reduction in the asynchrony, but a weaning failure, and the duration of mechanical ventilation was lesser in the PAV plus mode. Again, in this 2022 study done by Campolis et al., they had a moderate certainty evidence that proportional assist ventilation increases the weaning success and shortens the mechanical ventilation duration. Also, length of stay in the ICU as compared to PSV. These all are meta-analysis done over patients, over a greater number of patients. For example, the study done in 483 patients. Despite of this previous findings, why does this promising trial did not show similar outcomes or not the benefit for proportional assist ventilation? Well, the authors pertained it to various different reasons. For example, they said that since the patients were kept in pressure support ventilation group, they were expertly titrated monitoring of this particular patient, which doesn't mimic real life monitoring and care of the patient, which happens when they are kept on pressure support ventilation. And hence the chance for proportional assist ventilation to show its superiority never got flourished. Again, they said that since this is a large amount of population was used for this study, it was a heterogeneous patient population. So mixed diagnosis might have diluted the effect of proportional assist ventilation, where it could have shown its benefit in certain patient group. For example, the patient who are in COPD. Another reason was that there are strict and protocolized weaning, which is not done in real life scenarios. They said that standardization of minimized practice limited the variability and reduced any detectable differences if they were to occur. Now we are switching over to the critical appraisal for this study. So did the study addresses a clearly focused research question? Yes, it absolutely does. The research question was that does earlier intervention by proportional assist ventilation in patients on mechanical ventilator reduces their days of intubation or not? So yes, they had a clearly focused research question. Was the assignment of participants to the intervention randomized? Absolutely, the assignment was randomized. Next question is, were all the participants who entered the study accounted for at its conclusion? Yes, any loss to the follow-ups was accounted for, and yeah, so all the participants did got accounted for in this study. Were the participants blind to the intervention? They were given absolutely yes, since they were on mechanical ventilation. There's no way that they could have known as to what mode of ventilation were they on, so they were blinded. The investigators were not blinded. They were clearly, they knew that what intervention is being given to the patient. At the same time, the person who is assessing or analyzing the outcome, they were blinded to the study. Were the study groups similar at the start of the randomized control trial? Yes, all the baseline variables were comparable in both the arms, PAV plus as well as PSV. Apart from the experimental intervention, did each study group receive the same level of care? Yes, speaking of nutritional rehabilitation, everything was at par when it comes to both the groups. Were the effects of intervention reported comprehensively? Yes, a particular power calculation was done, and yes, I can say that the effects of intervention were reported comprehensively. Was the precision of the estimate of the intervention of treatment effect reported? 95% confidence interval were taken when they were reporting the results of the study. So yes, the precision of the estimate of intervention was reported adequately. Do the benefits of the experimental intervention outweigh the harm and cost? I mean, we can't tell this because in this particular study, they didn't do a cost-effective analysis. So we cannot tell if the benefit outweighs the harm and the cost. Can the results be applied to your local population? Absolutely yes, because we have the ventilators with this particular mode, we have the patient group, and we have the expertise. So yes, the results can be applied to our local population. Would the experimental intervention provide greater value to the people in your care than any of the existing intervention? We can't tell that because as the results showed, there was no particular superiority of proportional assist ventilation mode over the pressure support ventilation mode. So when we talk about providing greater value to the people in our care, I can't tell that. Maybe more trials with a greater number of people and more robust methodology might be required to determine the same. Thank you.
Thank you so much, Dr. Dipanshu. That was really wonderfully presented and concise at the end. I would request our expert Rakesh sir to throw some light on this, sir. Manish sir.
Thank you, Dr. Raghav. You can hear me?
Yes, sir. Absolutely.
Okay, thank you. First of all, I must congratulate Dr. Raghav for such a phenomenal exercise. Dipanshu, God bless you. Krishna bless you. You did very well. Extraordinary presentation, very lucidly presented. I think the moderator is Dr. Soumya, right?
Yes, sir.
So I just want to understand from Dr. Soumya, Dipanshu has already done justice to the subject, that this paper looks very interesting, Dr. Soumya and Dr. Dipanshu, but how this evidence-based medicine we can transport to the bedside medicine. Although you have done the critical analysis, which I have seen, Dipanshu, and you have mentioned everything that it can be locally applied. But just to summarize in the interest of the mentees who are listening to us. So Dr. Soumya?
Yeah, so now we have a problem of plenty. So it's what is called is the garbage in, garbage out. So as we can see in the discussion, the previous meta-analysis, they do mixed variety of patients. It was suggested that's why the researcher hypothesized it would be beneficial. But when that's why the evidence-based medicine shifted from meta-analysis to a well-constructed clinical trial. So now when today's is a day, everywhere it has been throwing up on a workshop of systematic review and meta-analysis. So this is the time perhaps we go back to the multi-center clinical trial. So that was the whole point to selecting this study. Even though most of our PG students or postdoctoral students, they find something has to be the p-value has to be found. A negative finding is a scientifically maybe valid and justified, and that too from NEJM, it is a negative finding. Basically, their hypothesis was superior trial, but they couldn't find. So that was the whole idea.
So just to, the reframe and redirect what you have said, Soumya, a couple of things, and maybe, Tanmoy and Raghav can also add. So conventionally, the weaning, which has been decided is, if you talk about the spontaneous breathing trial, majority of the time, majority of the papers, they have been talking about pressure support ventilation versus SIMV versus TPs, right? So these are the conventional methods. To be very frank, when I went through this paper, it is something which has bring rejoice to my understanding. I was not aware of that the people are using proportional, the ventilation to an extent where now we have a meta-analysis where almost 4 meta-analysis, which Dipanshu has quoted from this paper, and which has surprisingly shown that the incidence of liberation is more with the proportional ventilation in comparison to your pressure support ventilation. Now, having said so, just want to understand, Soumya, the patients who have been liberated from the proportional assist ventilation, what was the incidence of reintubation in them? Because the reason why I'm saying, because, when I was going through certain articles, and specifically what they have seen, the patients who have been liberated, when it comes to the comparison between the CPAP versus the TPs methods, the CPAP causes early liberation. But if you see, the incidence of reintubation has been much more in the CPAP category. If you compare the CPAP versus the TPs, it may not be directly in the scope of this article, but in the interest, so that the people, the mentees can assimilate that how they're going to use these 3 methods of weaning or the liberation when the patient is going to be taken up for SBT. So
regarding the question of reintubation,
yeah,
in the first group or the PAV plus group, they were having around 22.2% incidence. And the other group with pressure support ventilation, it was 23.3%. So
more or less same.
More or less same. There is no absolute difference between them, significant.
Okay. Now, the reason why I'm saying, because, if you go back to the literature, apart from this paper, Soumya, what they have seen, the patients who have been given a trial of TPs to facilitate the liberation from the ventilator, they have a lesser chances of reintubation. Given the fact that the TPs trial is taken as much more difficult test to pass. So if one passes the TPs, certainly the chances of coming back to the ventilation is less. However, because it is tedious and tiring, so we generally try to wean the patients on the CPAP or on the pressure support. So that is what the conventional teaching which we have been learning. Now I'm just more interested in that very soon we should be having a trial where the proportional assist ventilation should also be compared with the TPs, right? And then maybe we can have much more data to understand and to dissect. But for sure, by the way, are you using proportional assist ventilation, Raghav, for weaning? I'm not using. That's why I'm asking.
Sir, not at
so
all.
It looks so. When Dipanshu said it can be locally applied, I was fascinated by the fact that it can be applied locally. But till this paper, I have never been using proportional assist ventilation for the SBT trial. Yes. So one thing, is something which is very new for us, that proportional assist ventilation is as good as at least the pressure support ventilation to facilitate the weaning. In fact, when I was going through this paper, which we are presenting today, I also discovered that pressure support ventilation based weaning methods predisposes the patient for the over support and all those kind of things which has been mentioned in this paper. So a lot of new things we have added for our mentees, but for sure, just to recapture and recapitulate for our mentees, they must understand conventionally the liberation from the ventilator, which is spontaneous breathing trial, has been done more with either pressure support or SIMV, which we have taken off now, or the TPs. So these are the common methods. And CPAP versus the TPs methods, both of them have been found to be comparable, right? Many of the surgical centers, especially in France and all those kind of places, they use TPs methods much more common. While if you talk about the UK base, they are using much more the CPAP based method. But now we have an additional pressure support, proportional assist ventilation, which looks very, very fascinating. And let's not jump to the conclusion on the basis, but yes, Dipanshu and Soumya, you have given us 4 good meta-analysis to reflect and to ponder that proportional assist ventilation can actually lead to and increase the liberation rate. Although not the promising trial, but yes, certainly we have evidence. So thank you. This is what is my submission, Raghav.
Absolutely. Thank you so much, sir. Rakesh, sir.
Yeah, Dr. Manish has nicely summarized. Only one thing which is upcoming is we do not have evidence. It will take some time. Certain evidence is translating from perioperative period to the critical care aspect is the use of HFNC. So when we are talking about these aspects, it is not only leading to delayed ventilation on mechanical ventilation, but also people have started doing a couple of cases and studies which are ongoing, wherein an early extubation, like we used to do early TPs, which Dr. Manish Bharti mentioned, or when we say the RSIs and other things which were being monitored for these patients, the early extubation is done and then they are supported with HFNC and then wean it off. So this is upcoming. So this will be a research idea. Not many articles, RCTs has been done. So people can take it as a research idea. And I'm sure as far as the initial phases of intubation, it has been seen that it has delayed the intubation rate as well as decreased the number of patients on mechanical ventilation, because we understand the invasive ventilation have its own implication with regards to VAP and other complications. Probably not very robust evidence as of now, but I'm sure within the next 3-4 years, we will actually see that it's really is benefiting the patient from overall mortality and other aspects and lesser chances of hypoxic injury. So it's open for research, and I'm sure that many of you who are listening to us will have fair research idea for intubation and extubation in critically ill patient, the usage of HFN.
Thank you so much, sir, for your valuable inputs. So shall we move to the second presentation now?
Yeah, please, Dr. Raghav.
So
we don't have Tanmoy with us today?
Probably, yeah, he's just on the way, sir. So
Achha, no problem. Let's continue, Raghav. Let's continue. Thank you.
So I would request the second team, Dr. Monica. She is an IDCCM registrar in Department of Critical Care Medicine at Coimbatore, Kuppuswamy Naidu Memorial Hospital, and she's being moderated by Dr. Satyamurthy, who is a consultant intensivist. So I would request Sir and Dr. Monica to kindly share their presentation.
Thank you, sir.
Can you, yeah, sir, thank you. Full screen.
Good evening, everyone. Thank you for this opportunity. Today, the second journal is about Bicar ICU-2 trial. This trial studies about the use of sodium bicarbonate for severe metabolic acidosis and acute kidney injury. Background: due to severe metabolic acidosis, there are reported consequences like impaired cardiac contractility, arrhythmias, and pulmonary vasoconstriction with systemic vasodilation, altered kidney blood flow, and cerebral edema with diaphragmatic dysfunction. These all factors will lead to adverse effects on the patient outcomes. Hence, the treatment of the acidosis is a very important factor in the outcome of the patient in critical ICU. In acute kidney injury, the most common causes for metabolic acidosis are hyperchloremic acidosis and lactate accumulation and the endogenous anion accumulation. For these factors, the administration of intravenous sodium bicarbonate will benefit or not, which remains still controversial. Among the acidosis, in non-anion gap metabolic acidosis, that is hyperchloremic metabolic acidosis, this is because of bicarbonate deficiency, and eventually the kidneys will regenerate bicarbonate on their own, but this can take days. So the exogenous bicarbonate will hasten the recovery. And in uremic acidosis, the giving bicarbonate will be helpful to avoid the dialysis. But in ketoacidosis, in lactic acidosis, the use of bicarbonate is not beneficial. The recent studies regarding this sodium bicarbonate infusion is there are 4 studies in which the 3 retrospective studies. The first one was published in September 2018. In this study, they included elderly septic patients with acute metabolic acidosis. In this study, they have concluded that the sodium bicarbonate infusion may be benefit, but only in these specific subgroups with elderly patients with severe metabolic acidosis in sepsis. The next study was published in October 2019, which studied about the association between use of sodium bicarbonate and mortality in the acute kidney injury. This study concluded that only the sodium bicarbonate appeared to be beneficial in patients with severe bicarbonate deficit, but not beneficial for patients in acute kidney injury and with acidosis. In this retrospective study, which was published recently in June 2025, the sodium bicarbonate administration for metabolic acidosis in ICU were from 12 Australian ICUs were studied as a retrospective cohort study. This study concluded that the primary outcome is 30-day ICU mortality. The bicarbonate administration was associated with a small but statistically significant reduction in the mortality for patients with metabolic acidosis in 30-day ICU mortality. And our study is based on this Bicar ICU 1 trial, which were done by the same group. In Bicar ICU 1, they studied the use of 4.2% intravenous sodium bicarbonate with no sodium bicarbonate in an unselected critically ill patients with severe metabolic acidosis. They kept a primary outcome of day 28 mortality, organ failure on day 7 or both, but they concluded that the primary outcome does not differ significantly between the groups. But during the analysis, they saw that in patients with moderate to severe AKI, the day 28 mortality in control group is significantly high when compared to the bicarbonate group, which is only 46%. And also the renal replacement therapy, which was received in the control group, is 73%, but in bicarbonate group it was only 51%. Based on these two results, the Bicar ICU 2 trial was conducted. This Bicar ICU 2 is a randomized clinical trial that studied the use of sodium bicarbonate for severe metabolic acidosis and acute kidney injury, which was published in JAMA in June 2025. The important question here is, if the sodium bicarbonate infusion with a target arterial pH of more than or equal to 7.3 will reduce 90-day all-cause mortality in critically ill patients with metabolic acidosis and acute kidney injury. This study is multi-center, open-label and randomized control trial. This trial was done in the adult ICU patients with severe metabolic acidosis with a pH of less than or equal to 7.20 and in patients with moderate to severe acute kidney injury, the KDIGO classification of stage 2 or 3. Here, the patients are centrally randomized by computer-generated allocation sequence. The 640 patients were studied in 43 French intensive care units. The study period is from October 6, 2019 to December 19, 2023 with 90-day follow-up, and the last date of follow-up was June 17, 2024. This sample size was calculated from the previous study in Bicar ICU 1 trial primary outcome results. Here, to obtain 80% power with the detection of 10% absolute decrease, they decided that they needed 588 patients. And with they assumed that less than 8% of patients would have an unavailable data, and therefore they plan to include a total of 640 patients with 320 in each group. Inclusion criteria were patients older than 18 years with a total SOFA score of greater than or equal to 4 with with an arterial lactate concentration greater than or equal to 2 millimoles per liter within the 48 hours after ICU admission. And the other factors include pH less than or equal to 7.20 with PaCO2 less than or equal to 45 millimeters of mercury and sodium bicarbonate concentration of less than or equal to 20 millimoles per liter and moderate to severe AKI, that is defined as stage 2 or 3 in the KDIGO classification. Exclusion criteria. They excluded the patients with respiratory acidosis with PaCO2 more than 45 mmHg while patient is breathing spontaneously, and if there is a proven bicarbonate wasting, that is via the gastrointestinal tract or via urinary tract, and in stage 5 CKD with baseline glomerular filtration rate of less than or equal to 10 milliliters per minute, and in ketoacidosis, and if the patient is already getting a sodium bicarbonate infusion before screening, or to be planned for getting a sodium bicarbonate infusion for the next 6 hours, and also a renal replacement therapy. And in exogenous acid poisoning like metformin, salicylate, methanol or ethylene glycol, these patients were also excluded. Pregnancy or breastfeeding patients excluded, and the patients with life expectancy fewer than 48 hours were also excluded from the study. This is the concept chart for the study. Initially, 3,202 critically ill patients with acute kidney injury and acidosis were screened for eligibility. Among this, the following patients were excluded based on the exclusion criteria, and finally, 640 patients were randomized into two groups, 320 in the sodium bicarbonate group and 320 in the control group. In the randomization, it was centrally performed, which was using a computer-generated allocation sequence. The stratification was also done by using two factors. One, age, less than 65 years versus more than 65 years, and pH, less than 7.10 and more than versus 7.11 to 7.20, to balance between the two groups with a ratio of 1:1 by minimization. After the randomization, in the primary analysis group, 314 were included in the bicarbonate group and 313 in the control group. And at the end, during the per protocol analysis, due to the crossover from the control group who received the sodium bicarbonate, 349 were studied in the bicarbonate group and only 252 patients were studied in the control group. The management includes, this management is common for both groups, that is the indications for renal replacement therapy. In both groups, if the patient has an hyperkalemia of more than 6.5 or with the ECG signs or cardiopulmonary edema with no output, and the PaO to FiO2 ratio of less than 200 with the requirement of FiO2 more than 50% and with peak 5 centimeter. And also in the after 24 hours, if the patient has urine output less than 0.3 ml per kg per hour for at least 24 hours, arterial pH of less than 7.20 despite the resuscitation, and in hyperkalemia, any two of these include, the RRT was initiated in both the groups. And the intervention for the sodium bicarbonate group is by administering 4.2% sodium bicarbonate by targeting an arterial pH of 7.30 or more throughout the next 28 days or until the ICU discharge, whichever is earlier. And each infusion consisted 125 to 250 ml bolus of sodium bicarbonate within 30 minutes with a maximum of 1000 ml within 24 hours after enrollment. And at the end of infusion, every 1 to 4 hours, blood gas analysis were done to target the pH. Controls did not receive any infusions or placebos. The outcomes were studied, which were collected by the investigators. The primary outcome is 90-day all-cause mortality, and the secondary outcomes, initially they decided secondary outcomes are day 28 and day 180 all-cause mortality, the use of kidney replacement therapy, that is defined as any day the patient received kidney replacement therapy, and day 7 SOFA score. But during analysis, they saw the factors and they also included the following factors in the secondary outcomes, like the use of vasopressors, invasive mechanical ventilation need, ICU and hospital length of stay, fluid balance and other infections, and major adverse kidney events. Statistical analysis. They performed with the use of software SAS version 9.2 and R version 4.4.0. Two types of analysis were done. First, primary analysis were done after the primary randomization and excluding the other with the exclusion criteria. At the end, they did per protocol research analysis in which the patients who received sodium bicarbonate were compared with patients who did not receive sodium bicarbonate, regardless of their initial randomization group and regardless of their timing of administration. Outcomes. The primary analysis of this is the day 90 all-cause mortality, which was evaluated with the chi-square test and plotted as a 90 with the 95% confidence intervals. In these analysis, to confirm to overcome the confounders, they also did the randomization strata using center, pH, and the age. This is an open trial, and to prevent the robust odds ratio, they also studied a post hoc inverse probability weighting analysis to overcome that crossover between the randomization groups. The secondary outcomes, these were evaluated using the median difference with 95% confidence intervals. In this, the biological parameters over time, they were studied with mixed regression model, and the statistical significance was set as 0.05. In the results, the baseline characteristics of the patients, all the baseline characteristics including age, gender, and other comorbidities with the complications, SOFA score, and other laboratory parameters were comparable and equally balanced between the two groups. And in the outcomes, in the primary outcome, there is no significance between the bicarbonate group and the control group. That is, in day 90 all-cause mortality. In bicarbonate group, the number is 195, and in control group 193. Hence, there is no significance between the groups. The only significant in the secondary outcome is the use of kidney replacement therapy by day 28 is significantly low in the bicarbonate group, which is 109, and in control group it is 157. That is the one in the bicarbonate group, the use of kidney replacement therapy was delayed, and it is less in the bicarbonate group when compared to the control group. But in other secondary outcomes were not significant in these groups. So here the primary outcome was plotted in the Kaplan-Meier's curve. As we can see here, both the bicarbonate group and the control group, the lines are overlapping, and there is no significance between the two groups. And this primary outcome is compared in all the subgroup populations with the pH, age, SOFA scores, and other complications like a hemorrhagic shock, cardiac arrest. But in all these groups, the primary outcome was not significant. In the secondary outcome parameters, the two parameters, one is the initiation of KRT, which is prolonged in the bicarbonate group when compared to the control group, and also the incidence of KRT in the bicarbonate group is very less when compared to the control group. As we can see in this curve, there is a significant difference between the two curves. So in the discussion, the patients with severe metabolic acidosis and moderate to severe AKI, the sodium bicarbonate therapy did not significantly reduce mortality within 90 days. But bicarbonate infusion in moderate to severe AKI reduces the incidence of renal replacement therapy as well as postpones the initiation of renal replacement therapy in the group. In the Bicar ICU-1 trial, the AKI is not an inclusion criteria, and the mortality benefit seen in Bicar ICU-1 may be attributed due to the study design also. Here, the strength of the studies are: the important clinical question is evaluated with patient-focused and the outcome measures, and it is a multi-center trial. The baseline characteristics were well balanced, and the data for the primary outcome were available for all the patients, and the standardized criteria were used for the RRT initiation. But the limitations of the study are: the study is the open label design, because this trial allows bedside clinicians to access to blood gas measurements, which is clinically necessary because given the severity of the patient's condition. And the sodium bicarbonate dose was not computed according to the laboratory test or the weight of each patient, but it was targeted individually with the target pH of more than or equal to 7.30 with a maximum dose of 500 milliequivalents of sodium bicarbonate during 24 hours. And in the 47 of control groups has also received sodium bicarbonate therapy, but however this was overcome by doing the per protocol analysis that showed that even though there is a crossover, there is no significant difference in the primary outcome. And the recommendation in both groups were made to initiate renal replacement therapy as indications like threatening hyperkalemia or acidosis or overload criteria. During these situations, the sodium bicarbonate infusion can increase the pH, and therefore in the bicarbonate group it may be delayed KRT initiation by lessening this influence of acidemia criterion. The conclusion: for critically ill patients who had both severe metabolic acidosis and moderate to severe AKI, sodium bicarbonate therapy did not significantly decrease day 90 all-cause mortality. Finally, the appraisal. Was the purpose of study conveyed plainly and rationally? Yes, the purpose was conveyed. Were the objectives of the study clear? Yes. Was the study design stated and adequately discussed? Yes, the study design was adequately discussed. And in methodology, was the trial protocol and statistical analysis plan was published before enrollment? Yes. And was the blinding? No, because it is the open label trial. And was funding involved? Yes, the funding was involved. The baseline characteristics are similar. Yes, the stratification was also done. Was there a control population or a comparison group identical in all aspects? Yes, all the characteristics are balanced as a 1:1 ratio. Was there possible bias? Yes, there were possible bias because this study is not blinded, and also there were the crossover between the two groups. In the results, sample size estimation and power is adequate. Yes, all basic data are adequately discussed. Yes, the outcome measures are properly defined and the confidence intervals were properly reported, and there are also dropout data which was included in the study, and the limitations were also discussed, and the study results can be applicable to our population, but the challenge would be the strength of sodium bicarbonate, because we use 8.4% sodium bicarbonate, but in that study they used 4.2% sodium bicarbonate. And the two studies were in the pipeline. One is the soda study, and then another one is the MOBIC study. The MOBIC study, they uses the sodium bicarbonate concentration as 8.4%. Hopefully that will give some benefits for our clinical practice. Thank you.
Thank you so much, Dr. Monica and Dr. Satyamurthy. Manish sir, expert views.
So I think Dr. Rakesh would like to express it first.
Yeah, sure.
Dr. Rakesh, and then maybe I can add.
Thank you, Dr. Manish. I think the bicarbonate is always a notorious molecule in the critical care unit. There have been, I think, since its origin for last 4 or 5 decades, sometimes it comes up as a good agent, sometimes it's a bad agent. And recently, we had a good discussion with regards to the resuscitation guidelines, whether it should be a part of the bicarbonate supplement or sometime to be provided. Now, one thing, I think this paper appears to give a good insight, but when we have its clinical translational value, we also need to understand that this molecule is not so bad, but yes, as with other drugs in critical care setting, it has to be used cautiously in an indicated group of population. Number one. Number two, as the article also has hinted towards the same aspect, we also need to understand that the bicarbonate infusion or supplement or administration is not an alternate to the other management. Say, for example, if there is fluid deficient, if there is deficient in the peripheral perfusion, which happens in critically ill septic sick patients, if there is a decrease in perfusion because of any reason, or there is some kidney profile changes, we have to look for the underlying causative treatment also. And when we think of that, if there is metabolic milieu at a mitochondrial level is leading to some component of acidosis, probably counteracting is not the same. I will give you a very gross example here, that if somebody has a burn, this does not mean that you put ice on it. If somebody has an acidic burn, this does not mean that we pour alkali into it for neutralizing it. This is a very gross example if you want to understand in a very gross way. Because when we give it, we get the disadvantage of both heat and cold. Both causes injury. We get disadvantage of both the acid and the alkali. Both are the same thing. If there is acidosis at the peripheral tissue level, and if we give bicarbonate to circumvent it, both can cause notoriously harm to the peripheral perfusion. So I think in this, if you see this good article, Dr. Manish Bhatt is smiling and he will add on something very important because he always remains updated and he is one of the great critical care physician globally now. So we have to use this molecule in an indicated population. Sometimes it can be used as a rescue measure. Yes, that's an important. So indicated, rescue, and treating the underlying lesion. Probably I will say that this may be the clinical translational value of this molecule that still will remain into our drug armamentarium of a critically ill patient. Dr. Manish Bharti, over to you.
Thank you, sir. I always learn, and I'm just, I was getting late and I was so enthusiastic that I have to listen to Dr. Rakesh comments because you always come with, icing on the cake. Satya, you did a great job. I really enjoyed Satya. You are IDCCM candidate, I think, first year for yourself.
Yes.
So wonderful. You have a great mentor who is sitting along with you, Dr. Monica Mohan Kumar. And it is always good to have a teacher along with you, and great support from Dr. Mohan. I already, Dr. Rakesh has highlighted, but I just would like to know from Dr. Monica Mohan Kumar, if he would like to add something, that how this paper, this evidence is likely to make an impact in the bedside medicine. What is your take, Dr. Mohan Kumar?
So in severe acidosis and in AK,
Do we have doctors, your mentor with you?
Yes.
I would like to listen to sir. Yeah, please. Thank you, sir.
Sir, and severe acidosis as a rescue therapy, definitely yes, we do give doses. But then giving 500 ml in a day for if it is, see, they have told they can give up to 1000 ml a day for 4.2. 8.4%, 1000 ml a day. I don't know. I've not even heard of somebody using, and I get into hypernatremia most of the time when I use. So this specifically they're not mentioned in the study, because Bicar ICU, at least they reported that first Bicar ICU 1, they reported the incidence of hypernatremia was high, alkalemia was high, hypokalemia was high. But in this study especially not mentioned about the electric imbalance phase. I think the volume that they've used is quite high. So
up to 1000 ml you can use. This is what they have said.
Yes, sir.
Not in all the cases.
4.2%. In 24 hours.
Do you endorse on the basis of this paper and discussion which we have learned from you and your mentee as well as Dr. Rakesh? Should we endorse use of soda bicarbonate? If we have to simplify for the mentees who are going to use it, soda bicarbonate, let's say somebody is standing bedside, in what terms and condition would you endorse them to use soda bicarbonate therapy so that it becomes practically a handy tool for them? Should I use or should I not?
If it is severe acidosis, say it is less than 7.20, and then it is not something that we can, it's easily resuscitatable. Like a patient has got hypovolemia, and then that's the reason why he's in shock because of hypovolemia. I'm giving fluids, I'm trying to treat the cause. Then I don't think we should be even thinking of using bicarbonate at all. But a patient has already have AKI, is not able to regenerate bicarbonate. In that case, rescue therapy we can use in small liquids. That's what I think.
Thank you, Dr. Satya. I would just like to add, what I have learned from my experience and from what Satya has delivered, and my experience in the Middle East. Raghav, this is very fascinating. Bicarbonate therapy has been, as Dr. Rakesh has said. First of all, you said that 4.2% is difficult for us to deliver. No, you just have to make 50% dilution. You double dilution, it should work. Yeah. We have 8.4%, and previously we were having a 7.5%. So it's easy. You just have to dilute it to 50%. Yes. But few things the mentees, they must learn when they're using a soda bicarbonate therapy. One, the role of soda bicarbonate therapy should not be in the moderate to mild acidosis. It should never be. It's only the life-threatening metabolic acidosis, as Dr. Rakesh and Dr. Mohan Kumar has highlighted clearly, that the role is limited to a life-threatening metabolic acidosis where it has a tendency to precipitate hemodynamic instability, right? That is one. The role of bicarbonate is very clear for NAGMA, which is normal and anaerobic metabolic acidosis, because they lose bicarbonate in either GI fistula or the loose motion, whatever could be the stuff. But it should never be, or it should restricted to be in usage for HAGMA, which is high anaerobic metabolic acidosis. That is second. Third, it should never be used as a treatment in specific acidosis like DKA. The threshold for DKA should be very, very high, which means unless and until your pH is 6.9 or 7, it should be strongly discouraged. So I'm just trying to simplify for the mentees. Another important thing which we must understand. See, when I was working in a developed setup, I'm talking about Middle East, my experience, Raghav and Dr. Rakesh, and sir, with all respect to you, they're the people who have a very low threshold for starting CRRT. So CRRT is easily available for them, right? So if you can start CRRT and take care of, the adversities and adversities in the form of acidemia, hyperkalemia, and all these things, it works wonders. The problem is there when you are in a developing setup. In a developing setup, in a resource limiting settings, you are not loaded with the infrastructure. So in that situation, your intention is to delay the diagnosis, delay the dialysis. I won't say delay the analysis is not the right word. Rather, I would say I will like to highly rationalize the usage of dialysis in a resource limiting settings. Now, the interesting, the conclusion which I have gained from this paper, especially for the patients who are having a Kitgo stage 2 and 3, which I think the mentee has highlighted, there, if you're using soda bicarbonate therapy, you can actually postpone the CRRT. Now, of course, mortality benefit is not there. But let's say I'm working in a resource limited setting, CRRT or any kind of a dialysis is going to take some time. So to buy time, to postpone the incidence of renal replacement therapy, I may still consider soda bicarbonate therapy with the context and within the inverted commas, it's not going to change the mortality. So it is going to buy time. And I think we have been using it for the same reason. It's just that now the validation is there in the form of evidence. No, Raghav? So I've been using it for, when Dr. Rakesh used to be my SR and when I was his PG, even then we used to use soda bicarbonate therapy liberally to postpone the dialysis. And sir will agree with me. So now we have a complete acceptance, at least for this part. The second thing which you said, sir, is that, what is very surprising and which I fail to understand, and maybe anybody can answer. In Bicar ICU 1 trial, which was in 2018 in Lancet, they saw a mortality benefit at least for the first 28 days if they were using bicarbonate for the patients who are having a severe acidosis. I fail to understand why the mortality benefit has not been seen now. So do we have any opinions? Because there, I still remember, I was in transplant and I used to encourage my transplant, the doctors over there that we should consider soda bicarbonate therapy. But now they are saying that there's no mortality benefit. So why there is a discrepancy between the Bicar ICU 1 and Bicar ICU 2 trial, difficult for me to capture at least. So if you can add, please.
In the study itself, what I mentioned is one is the study design. They didn't include AKI in the first study. That is what they've told, sir. Second, what they've told is that the number of centers that were included were more this time. So centers that were new, probably that also added to this change in the results. But it was not very what you call the reason given is not reasonable.
Not clear, na, Dr. Satya? Yeah.
Yes.
So I was confused because there they are saying 28 days composite mortality, at least in the one subgroup, was seen beneficial. So as the final bottom line, I would say, as Dr. Rakesh said, it is always a fascinating drug, always come with surprises. I think a lot of things depends upon the kind of a setup we are using, but at least for the developing setups and the setups where we are working in a resource limited settings, bicarbonate can help you at least in the rationalization of your the resources, at least to my time. That is what I feel should be the submission from my side. Over to you, Raghav.
Thank you so much, sir, for summarizing it so well for both the papers. And yes, I totally agree to your point that we still are using it to buy time before we are able to initiate the CRRT modality. So absolutely, sir. And as Rakesh sir also mentioned, that we must always focus on treating the causes why the patient is developing the acidosis before we jump on to giving bicarbonate. So this is for all the mentees who are attending. And just one question has come from one of the mentees. So probably Dr. Monica, if you'd want to answer, one of the mentees wants to ask, what's the difference between 4.2 and 8.4% of bicarb? So Satya sir, or this is, I guess, very...
We already answered it, Raghav.
So, yeah.
You just have to dilute it by 50%. Yes. In fact, soda bicarbonate is extremely hyperosmolar. It's an osmolarity of close to, I think, approximately 2000 milliosmoles, 1960 or something. So you have to really dilute it to be given through the peripheral line. I think up to 3 times you can give it through the peripheral axis. And that is the reason why, you can make it at least 50% dilute. This is what, I was able to capture.
Thank you so much, sir. So thank you to both the teams from Chandigarh as well as Coimbatore for a wonderful presentation today. And we have been able to finish both our presentations in time with a very good discussion. So thank you to the mentors. Thank you, Manish sir. Thank you, Rakesh sir. And thank you to Dr. Tanmay also. Probably he lost connection in between, but he has been an active part for this webinar today.
So thank you. I would like to express my sincere gratitude to Tanmoy and Raghav for being such a wonderful moderators. Of course, we are missing Tanmoy and my co-guide, which is Dr. Neeraj. Unfortunately, he's also stuck. But as you have been always doing this show flamboyantly, we really appreciate your efforts. And once again, congratulations to the team, Chandigarh, Dr. Dipanshu, Dr. Soumya, Dipanshu, extraordinary presentation, and as well as Dr. Satya and Monica. Sorry, I exchanged the name, so I was a bit confused. So I apologize off lately. And of course, we are highly obliged to ISCCM for giving us this activity, especially Dr. Ranveer Singh Tyagi sir, who has been a benchmark in the conception of this concept. And we are going to be there every month, Raghav, the third Friday of every month. And of course, we have many more, the new academic activities coming up. So thank you for being there.
Thank you. Thank you, sir. Thank you for the opportunity.